Thank you very much, Willem, for that introduction, and thanks everyone for coming this morning. I think it's really exciting to see this education session come to life, and thank you to Willem for your vision in putting it together. It is a lot of information, so I'll try to get through it somewhat quickly, but this is just a little bit of background about metastatic breast cancer. And first of all, what is metastatic breast cancer? So anytime that breast cancer has spread beyond the breast and armpit via either the bloodstream or the lymphatic system to a different part of the body, it's considered metastatic or stage 4 disease. It can spread to any part of the body, but the most common sites would be the bone, liver, lungs, and then less commonly the brain and the skin. We can also see metastases to the lining of the abdomen and lining of the lungs, which sometimes lead to fluid production, which can look like either pleural effusion or ascites in the abdomen. Next slide, please. So at any given moment, just over 1,000 people are living with metastatic breast cancer in our province. This includes people who are newly diagnosed, women on active therapies, and dealing with end-of-life care. Similar to early breast cancer, 99% of patients living with metastatic breast cancer are women, but there are 1% male. So the majority of the women who are living with metastatic breast cancer have had a prior diagnosis of early stage breast cancer, so are presenting with relapsed disease. So just over half of patients we see present with relapsed disease, whereas just under half present with de novo or metastatic disease as their first diagnosis. It's really important that survival time with metastatic breast cancer has been increasing over time. So how do we diagnose metastatic disease? Oftentimes, for patients who have higher risk early stage disease as part of their workup, we'll do an initial CT chest, abdomen, and pelvis to look for metastatic disease. But for patients who have been previously treated for an early stage breast cancer, we focus our imaging on symptoms. So for example, we do routine clinical examination, routine physical and history, and target our imaging investigations around patients who are having symptoms. If we suspect that there's metastatic breast cancer, that's when we would do a workup, including CT scan, basic lab tests, and brain imaging if there's any sort of neurological symptoms. Occasionally we'll recommend, or often actually, we'll recommend biopsying a site of metastatic disease to confirm the diagnosis and also help guide our treatment. Next slide. So part of the reason that biopsies are so important in breast cancer is because there's different types of breast cancer. We know that they behave quite differently, and we actually treat them very differently. So biomarkers are really important in guiding our treatment. A biomarker is essentially a molecule that can be found on or within cancer cells. Normal breast glandular cells will express the estrogen receptor and progesterone receptors, and they respond to female hormones for growth and function. So some breast cancers will have high expression of these receptors and use estrogen circulating in our bodies to signal the cells to grow and divide. So you can see in this diagram here, the way that we measure an estrogen receptor is by using a stain. And it can be varying degrees of positivity based on how dark that stain is and how much of the slide stains positive. HER2 is an important biomarker that's really changed our treatment paradigms. Historically, it would have been a bad type of cancer to have, in the sense that it tends to grow more quickly and is a higher risk of recurrence. But we've gotten really, really good at treating this type of breast cancer, so it's actually now a favorable prognostic marker in the sense that we have a lot of treatment options available for it. So these are sort of the broad types of breast cancer by biomarker profile. They can lead to these three broad categories, but we do recognize that within these broad categories, there's certainly heterogeneity or differences within them. So there's the hormone receptor positive and HER2 negative group, which we often call the luminal type, HER2 positive, which can be either hormone receptor positive or hormone receptor negative, and then of course the triple negative type, which would be negative for those 3 receptors. Again, within each of these groups, there is heterogeneity, and there's different mutations that we're learning more about. And as we learn more about them, we can guide our therapy more individual to a person's tumor. So, for example, within hormone receptor positive disease, there's a mutation that about 30% of women will express called PIK3CA. And then within triple negative breast cancer, we're learning more about the PD-L1 and NTRK mutations. PD-L1 has opened up options in terms of immune therapy. And then, of course, within all of the subtypes, there's the BRCA mutated tumors, which respond well to certain therapies as well. And then similarly, we can look at MSI high or mismatch repair as a way to look at possible immune therapy options. Next slide. But one thing that is always challenging about breast cancer, and that continues to be challenging, is the complexity and heterogeneity that we see. So there's spatial heterogeneity of metastatic breast cancer, as well as temporal. And what that means is, if you look at diagram A, speaking to spatial heterogeneity, even within an individual, different sites of metastatic disease can express different mutations and can respond differently to certain treatments, which is why sometimes if we're started on a systemic therapy, we'll see disease response in some areas where it's less effective in other areas of the body. There's also temporal heterogeneity. So over time, breast cancer cells will develop different mutations that make it more challenging to stay on the same therapy for an extended period of time. Sometimes we use the analogy that that metastatic disease can be similar to treating like a bacterial infection, in the sense that, you know, if you were to use the same antibiotic on the same bacteria for long periods of time, those bacteria gain resistance. And similarly, breast cancer cells can do the same.